Is on?
Yes.
Okay.
It's on.
So good afternoon to everybody. It's a pleasure for me to introduce this meeting on lung cancer screening. We believe and we hope lung cancer screening will become the standard of care even in Europe in the next years. And also we think that thoracic surgeons will be really important and key person in making this program working in the best way.
Yes, I can introduce myself. My name is Jasper Petersen. I'm a surgeon from Copenhagen. I've worked with lung cancer screening for 15 years at least now. And I'm also chair of the working group on lung cancer screening in the ESTS. And I hope we will have an exciting meeting with you. And I will introduce also Dr. Navi from the UK. Could you introduce yourself, please?
Yes, good afternoon, everyone. My name is Dr. Navani. I'm a physician in respiratory medicine from London with an interest in lung cancer screening.
And Doug, could you also say a few words about yourself?
Yeah, I'm Doug Wood. I'm the chair of surgery at the University of Washington in Seattle, and related to screening, I'm the chair of the National Comprehensive Cancer Network Lung Cancer Screening Guidelines Panel and vice chair of the American Cancer Society National Lung Cancer Roundtable.
Thank you very much. Okay, we'll start with the first presentation by Julia Verinesi.
Okay, so I will summarize a little bit the situation in Europe. These are my disclosures. And the reason why we need lung cancer screening is really clear to everybody. Lung cancer represents the fourth cause of cancer death in the Western countries, and in Europe, not only for men, but even for women, it became the first cause of cancer death. So we have also a target population which is related to the smoking history, and it is well known that when we find tumors because of symptoms, we have a diagnosis in 80% of cases in advanced stage of disease, but the screening, low-dose CT, can anticipate diagnosis and allow a curative treatment. So what is the situation in Europe today? We know that so far we are late in the adoption of lung cancer screening in Europe. We know that in US, after the release of mortality data of NLST, lung cancer screening has been adopted and implemented on the territory. And this didn't happen in Europe. The reason can be maybe shown by this slide, where you can see we had in Europe a number of very small and fragmented studies that so far were not able to demonstrate a reduction in lung cancer mortality, even if things are changing a little bit, and we will see why. Despite that, we know that we had a reduction of lung cancer mortality of 20% already demonstrated by a randomized study in the US, which included more than 50,000 people. And we are aware that the European study, even if combined, will never have the power to change the conclusion on LST. But this is a paper already published by the group of the Danish investigators, and we have here Jesper Pedersen as the PI of the study. And despite in the beginning it was not significant, the reduction of lung cancer mortality, then a later analysis, a secondary analysis of the results with a longer follow-up underlined that there was a sort of unfortunate randomization with increased risk in the treated arm compared to the control arm. In addition, a longer follow-up in a subgroup of patients could show that there was a reduction of 23% mortality in the screened subjects compared to controls in the group with COPD and higher smoker rate, more than 35 packs a year, which is not very different from NLST results. The other study in Italy, the ITAL-LUNG, with a longer follow-up, was able to demonstrate a reduction of 30% mortality, even if not significant for the small numbers, in the screen arm compared to the control arm. And this was also important to show that there was no overdiagnosed bias in lung cancer screening in this study, for example. So two important news about randomized trials. And then another new paper was published recently that merged the data of two Italian randomized studies, the MILD and Dante study, and with a long follow-up of 8 years, we could see a reduction in overall mortality of around 11%. So also the investigators themselves admit that there were limited power at the beginning to show any benefit of lung cancer screening. And everybody waits for the Nelson study results. It has not released the mortality data so far. However, what happens if the Nelson study will be negative? Let's hope it will be positive, of course, but even if negative, what can be the conclusion? The conclusion can be, according to the comments of Tamemagi published in 2014, that probably Nelson enrolled less cases than LST, so the power is lower. And also the risk, the average risk of the population is lower because the median PAC years is 38 compared to 48, and we know that screening is more effective in high-risk groups. And also can be probably an insufficient power due to suboptimal study design, and we know that there is 2 years and 2.5 years apart in the screening interval between rounds. So in Europe, we also have single-arm studies. One, for example, is the COSMOS study we run in Italy, in European Institute of Oncology. And the first COSMOS study, then we had another including 7,000 individuals in Italy in a network. The first study was followed for 10 years, 5,000 individuals enrolled in 1 year in 2005. And what was shown is the safety of screening and also some data on the management of nodules. We could confirm that the stage 1 and 2 disease were 80% compared to 25% in absence of screening. We could see a very low rate of recalls, 5-10%, which is much lower compared to NLST study, which was 27%. So the design was good in our case, and also a low number of false positive cases, even lower than in the routine practice in the same institutions. So 1.3 per 1,000 individuals enrolled at the benign lesion at invasive procedure. And the other objective was to evaluate the rate of overdiagnosis, and we identified all and calculate all the volume doubling time of the incident nodules. Thus, we expected 10% of indolent tumors resected among these studies, which is very low compared to other data, and even now is lower because we changed the policy of management of ground glass opacity. So the 5-year survival was confirmed very good, higher than 75%, and also we had data on the radiation-induced cancer, which was very, very low in the worst scenario. But important for lung cancer screening to be successful and cost-effective is to have the best target population at risk, and we could identify a risk model, through a risk model, the best way to select the population, and both for the baseline screening, but also to identify the best screening interval after baseline. So here you can see the model, the lung cancer risk calculator, which is not very different from the PLCO risk model. However, the two should be harmonized to obtain the best model for also interval of rounds. And also we could observe that in Europe we have not a very strong cost effectiveness analysis, except those that produced by the group of Field in 2016 that show 6,000 pounds of ICER for each year saved. And if you can see in red, we had very good preliminary results. It should be confirmed and published yet. However, this is important to see that in Italy we have around 3,000 euros for every year saved, and for QALY it became 3,200. So 1/4 of what is expected to the cost of screening of breast cancer. And also the probabilistic Monte Carlo simulation can show that lung cancer screening can be cost-saving in many circumstances, according to this data, and according to the fact that costs for advanced lung cancer treatment are higher and higher with immunotherapy. The target population has been calculated in Italy to be 2 million. And what about molecular markers? So far, you know that the only validated tool for lung cancer screening is low-dose CT. However, molecular markers are studies are ongoing to see if we can obtain improved sensitivity and specificity of low-dose CT, or even to have a pre-selection with molecular markers. These are all markers that we focused on for the future: serum microRNA, radiomics, and artificial intelligence for imaging, the circulating tumor cells, the plasma DNA mutation, and exosome antigens. So what about the future perspective? We know that we have a number already of recommendations. Most of scientific societies already recommend lung cancer screening in selected group of population, high-risk population, most international, but also European Society of Respiratory or radiologists. ESMO Society already recommend lung cancer screening, the French task force, and luckily even the most skeptical investigators that run the randomized trial changed their heart and now admit that lung cancer screening should be implemented soon in Europe, and we are late in doing so. My conclusions are that scientific community agrees on oncological benefit and safety of lung cancer screening. We have risk models to identify the optimal target population and the screen interval. We know from cost effectiveness analysis data from UK and Italy that is affordable and even maybe cost saving in the future, and molecular markers are under evaluation for a future assessment or clinical impact. So what remains is we should implement in Europe also an integrated prevention, personalized prevention program, including all smoking-related disease, lung cancers, cardiovascular disease, and COPD, and couple it with energetic smoking cessation activity. So we must convince our politicians to make new recommendations from the European Commission, and hope to do that as soon as possible. Thank you for your attention. We have questions at the end of the 3 presentations.
What kind of screening you would suggest? CT scan, a regular chest X-ray?
Yes, low-dose CT scan is the validated method. As said before, maybe we can do discussion at the end of the 3 presentations.
How do I get it out? It's not on the screen. How do I get it on the screen?
Okay, Jasper. It's up.
It's up, okay. Sorry. Yes. Yes, so the question, if we want to start screening, which is very, very relevant. In Europe, of course, it's not relevant yet. but it will come soon. So the question is, how can surgeons prepare for lung cancer screening? And this is what I will talk about for a few minutes. And first of all, I have no disclosures to report. And of course, if you're looking at what are the surgical aspects that the surgeon would have to prepare for, and this has also been covered by other groups than the ESTS, but as is shown here. And you can see that both the American Association for Thoracic Surgery in 2012 and 2013, and 14 and 15, and 15 and 2017, the role of the thoracic surgeons was described in a publication in the Journal of Thoracic Surgery, and this, well, in 17 also, the ESTS working group, which I was chair of, reported their conclusions about this and made 10 recommendations for partly a recommendation about implementation in Europe, but also how the thoracic surgeons to be involved in screening programs, both in the preparation and also in the actual screening programs. And also the requirements for the multidisciplinary capabilities and requirements to a screening center, and the diagnostic protocols, which of course are extremely important. Also looked at the qualifications of the participation surgeons and the use of minimal invasive surgery, which is very important. In addition, the recommendations also covered the collaboration with pathologists, which is crucial, and some specific surgical issues relevant to the screening situation. And also the issue of quality monitoring and education and central registration and certification of screening centers is very important. This, of course, does not involve the individual surgeon directly, but it's an important environment for the surgeon to operate in. So why should the surgeons be involved in the screening programs? First of all, the surgeon's perspective in the management of the screen-detected nodules is extremely important, because it's very important that they have a reduction of the false positive rates of surgical biopsies and also surgery for benign lesions, which I will come back to a little bit later. But in addition, also it's very important that the surgical trauma is reduced by the use of minimal invasive techniques, and this requires high quality surgery to be delivered safely. Also, the surgeons should be participating in the shared decision making prior to the screening, which in some countries may be done by the pulmonologist, but I think also the surgeons can have a very important role in this. Also, the surgeons should have an active role in the smoking cessation advice and practice in connection with the screening program. And of course, the surgeon has a crucial role in the MDT diagnostic and therapeutic planning of the individual patients. One of the issues, as an example, is the ground glass opacities, how to handle these. You will see a lot more of ground glass opacities when you do screening, and this is very important that this is an area which carries the risk of overdiagnosis and overtreatment. So therefore, there are some recommendations about this. One of these was that it's important to realize that the GGO nodules should be followed for a long time, at least for 4 years, perhaps even longer, depending on the size and the looks. And the PET-CT has a limited value in the workup of GGO nodules in the beginning, and when they're smaller at least. Also, we agreed that a development of a solid component in a pure GGO nodule or growth of a pre-existing solid component is indicative of invasive surgery and therefore also invasive malignancy, and should be considered for diagnostic procedures, invasive diagnostic procedures. Also, the careful considerations for the indication for surgery and longer follow-up, as mentioned, is crucial. And further research in this area is important, and I'm happy to notice that the ESTS has established a working group on the GGO lesions to make recommendations and guidelines for the management of this. That my colleague in Copenhagen, René Petersen, is chairman of this group. And other issue, which is important for the surgeons to consider before giving advice about screen-detected lesions, and also the indications for surgery, is the surgery for benign lesions, which in principle is something that should not be done, of course, in a screening situation, but all of us who have done screening must realize that this does happen, that even though we thought it was a cancer, it turns out to be a benign lesion. And this extent varies very much from 2 to 45%. And the current recommendations are to keep this rate below 15% at now. But in the ILCAP, for example, and also as Julia in the Cosmos trial, surgery for benign lesions was as low as 1 to 2%. And this, of course, is a very important goal for others to aim at. And we should learn from these groups that have good results to how to improve our results to avoid excessive surgery. In screening, a delay in diagnosis under close monitoring may sometimes be preferable to unnecessary surgery, and this is the surgeon's decisions when to go on to surgery. The extent of surgery for benign lesions should be monitored and reported as an indication of the surgical quality, and further research should focus on this issue also. So what are the qualifications of participating surgeons? Well, of course, the objective is to minimize the risk for useless invasive procedures for benign disease and avoid overtreatment. What happened now? Sorry. Yes, I'm in there. Okay. So and surgeons should be familiar and also competent in minimal invasive surgery techniques within units where VATS and robotic surgery and equipment is used routinely to perform lobar and sublobar resections. And national certification as a specialist thoracic surgeon, also called board certification, is recommended. And in Europe, of course, it could be the European Board of Thoracic Surgery certification, which is a preferred requirement that surgeons have this before engaging in surgery for screen-detected lesions. Participation in an individual, as an individual surgeon or unit to the ESTS database is also recommended, so that we have international standards and can monitor the morbidity and mortality. But of course, also surgeons should possess the necessary skills to communicate the results face-to-face with the patients, and should not be afraid to have these discussions with the participant. But many surgeons do this every day, of course. When you look at so the conclusions from the ESTS recommendations is that screening should only be done in MDT centers with MDT capabilities, and screening should always be in combination with smoking cessation. Treatment and invasive procedures should so far only be done in high-volume centers with minimal invasive capabilities. Data registration and quality control is essential, and sorry, this is not good. Okay. And initiation of national demonstration products in Europe is recommended, so that the European countries can get experience with screening trials, screening programs. Okay, that's my whole. So thank you for your attention. Thank you.
Well, good afternoon, everybody. Thank you very much to the organising committee for inviting me to speak. It's a real pleasure to be here. As a physician, it's my first ESTS conference, and it's been a real eye-opener. So I'm really enjoying it. I do have a few disclosures, but none relevant to lung cancer screening. So I thought it would be good to talk to a group of surgeons about money. So the next sort of 10 minutes is purely going to be about the cost-effectiveness of lung cancer screening. So why is it important? And I think it is a really important question for societies in all of our different healthcare systems to answer. And the main reason is lung cancer screening is potentially extremely expensive. The benefits from lung cancer screening will only be limited to a very small proportion of the population that will benefit, but the cost will need to be spread across the whole of society. So cost effectiveness is going to be really key to, as to whether we can realise the dream of implementing lung cancer screening around the world. So I'm just going to, over the next 3 slides, just very briefly remind us all about some health economics principles and how we work out whether something is cost effective or not. And it's simply by working out the difference in costs divided by the difference in health benefits, which gives us a cost effectiveness ratio. So Dr. Veronese has already mentioned the ISA. So this is the mean cost in a certain treatment B versus the mean cost of treatment A. So in our example, B is going to be low-dose CT scan for screening versus cost of A, which currently is standard of care. And then we look at the effect on the denominator of lung cancer screening versus take away the current effect of standard of care. And in this example, and this is not directly from a lung cancer screening example, you can see that if an intervention is £5,000 more expensive and gives us an extra 0.1 quality adjusted life year, then we conclude that the cost to society will be £50,000 per quality life year gained. Let's look at that in this sort of matrix. So if we find that in this example, that something is less expensive than what we were previously doing and gains us QALYs, then we say the treatment should definitely start straight away. The new treatment dominates. But if something is more expensive and not as good, then the new treatment is dominated. This is a slightly better situation where we're getting a few benefits of QALYs, but the intervention is very expensive, and we can work out the cost per QALY by the area under that line. But this is where we want to be, something that is not that costly, but gives us a lot of benefit in terms of QALYs. And most healthcare systems will have a set cost per QALY threshold. Certainly in the UK, that's thought to be around £30,000 per QALY, and anything that falls below that line is felt to be cost effective. So how do we work out whether something is cost effective? How are we going to know whether lung cancer screening is a cost effective thing to do? So we have to work out the unit cost, which is cost per CT scan. We look at resources, so cost of clinic visits, inpatient stays, cost of participant time to go and have their screen. We then need to incorporate how good is the test, how good is low-dose CT screening, particularly focusing on false positives as well as the sensitivity, looking at what the impacts are on treatment in terms of survival and health status, adjust for quality of life measures, and then apply that using epidemiological techniques across a population and seeing whether there are perhaps certain groups and risk groups that may benefit more or less from screening. So overall, we create a model. We use the clinical data available to us from clinical trials mainly, and we create a model that gives us our cost per QALY. So let's look at the biggest trial of this. As we all know, the National Lung Screening Trial, which showed a 20% reduction in lung cancer mortality. I want to just remind you that there was a big stage shift in this trial where 62% of patients had stage 1 disease, and only 12% of patients in the trial had stage 4 disease. So a big stage shift from what we're currently used to, which between 20 and 30% with stage 1 disease and 40 to 50% in stage 4 disease in clinical practice. So what about the cost effectiveness of CT screening in the National Lung Cancer Screening Trial? This is obviously a major publication in the New England Journal of Medicine, but it's important to read the small print and understand where this cost effectiveness has come from, because they created a model that incorporated several assumptions. So they estimated life years beyond the follow-up of the trial using life tables. They also assumed that somebody who had a positive scan that was a false positive scan did not lose any quality of life detriment, and there is some data to support that. And contrary to some other healthcare systems, they used costs based on reimbursement rather than actual costs to society. They looked at quality of life in a subset of the population, so about almost 12,000 participants completed the SF36 questionnaire. So this is a standard quality of life measure, and it helps us to adjust a person's quality of life. So 1 would be perfect health, 0 will be death, and what they showed is that patients in the National Lung Cancer Screening Trial had a mean utility of 0.76 and 0.74 at baseline. So let's look at some of the results of that. Well, in patients with lung cancer, they showed that in the CT arm, the quality adjusted life expectancy was 6 years, 6 QALYs, versus in the chest x-ray arm, you remember the control arm in that trial was chest x-rays, of 4.8 years. So there's clearly a gain in QALYs for implementing low-dose CT scan. But at what cost? So these are the costs per person, and about $1,000 per person for screening, $835 for workup, and $1,100 for treatment, and lower costs in the no screening group. But I did want to highlight, and Dr. Veronese sort of just touched on this a bit, that things have moved on from these costs really, and the costs that they highlighted in the trial of chemotherapy, for example, are perhaps slightly lower than we would expect for treating patients with advanced disease now. So overall, they calculated a cost per QALY from the National Lung Cancer Screening Trial of approximately $81,000 US, so below the sort of accepted threshold in the US of approximately $100,000 as a cost per QALY. But you'll see just below that final figure that there's quite a large confidence interval. So why is that? So when you build a model, you're able to change a lot of the parameters and see how they affect the incremental cost-effectiveness ratio. And they varied a number of these things, and some of them significantly affected the cost-effectiveness of it. And importantly, particularly for this audience, is the surgical mortality. So if you simply change the surgical mortality by a very small amount, you can change the cost-effectiveness of CT screening enormously. Clearly, if the costs of CT scans change, follow-up examinations, and also if you change the cost of future care, you can significantly change cost-effectiveness. So we've got a big potential range in which the true value may sit. As you may know, in the UK, we ran a pilot randomized controlled trial called UKLS of low-dose CT screening versus no screen, and it was a single CT scan only, unlike the National Lung Screening Trial, which was annual low-dose CT for 3 years. And because this was a pilot study, the full study was not funded, we had to use the mortality benefit from NLST to try and extrapolate a cost-effectiveness analysis. And we found that in the UK healthcare setting, there could be really significant value in introducing a low-dose CT program with you can see a ratio there of under £8,500 per QALY gained. And if you vary all of the parameters that go into it, even quite wildly, you still stay well below the cost-effectiveness threshold that supposedly society is willing to pay. So we think this is strong evidence that, at least in the UK healthcare system, we're trying to push this forward really as quickly as possible. So it would seem that lung cancer screening by low-dose CT would be cost-effective. But what about if we start to try and play with some of the policies around lung cancer screening? So what if we were to change the starting and stopping age, or to change how frequently we were to scan, and what about the patients with different smoking histories? So we can actually introduce all of those things into the model, and this really important paper published last year in PLOS Medicine did do that. So they considered various different ages at which to start screening, the age at which to stop, and various different accumulation of PAC years, either like the NLST trial or various different scenarios of smoking like the Nelson trial. So this is, I think, really interesting. I think there's a very clear bottom line, though, for me. All of the figures, regardless of where you set a lot of those parameters, are cost-effective. So even if you were to broaden lung cancer screening to a much wider age range, so say 50 to 80, so beyond what NLST did, or and you actually lower the smoking threshold for entry into the trial, yes, you increase the costs to society, but overall it's still cost effective. And the data into this model was put in from Canadian low-dose CT scanning data, and these figures are in Canadian dollars. So there's a lot of interest now currently about trying to select patients for screening much more accurately. So can we define a high-risk group in the population out there that may benefit more from low-dose CT screening? And would that translate into better value for the healthcare system? So this is a really interesting piece of work by Dr. Kumar and colleagues, published only a few weeks ago in Annals of Internal Medicine. And there's a few lessons, I think, from this, and this is an important graph. So if we've got lung cancer mortality risk along the x-axis, and as you can see, as the mortality risk from lung cancers, these are high-risk patients in the population. If you screen them, they get considerably more life year benefit. So that's the point far right. So they get significantly more lung cancer mortality benefit. But actually their life years that they gain is much more attenuated than for those at the lower mortality risk, which means their gain per QALY is not as much. So you can see that the top group of dots takes off really nicely, but the bottom group of dots, which is the cost effectiveness, is not hugely different. And this is probably due to competing mortality. So those patients who are at high risk of lung cancer are also at high risk of other diseases, other cancers and cardiovascular disease. So their benefit from the cost benefit from introducing them into a screening program may be slightly lost. And we see that again here, where overall there's a slight decline in ISA per QALY for those at the higher lung cancer mortality risk. But I would conclude from this that even in the high risk group of patients, there is still clearly a cost effectiveness benefit. Comorbidities, I think, is going to become a really important issue in lung cancer screening, and it may be that we are doing a disservice to people with lots of comorbidities but who meet current screening criteria by putting them into screening programs. And what we haven't yet really established is the cost effectiveness of entering those patients into a screening program. And I understand that there's due to be a document published by the American Thoracic Society on this shortly, on the role of comorbidities in selecting patients for lung cancer screening. I've just got a few more slides, and I wanted to raise two more important points about cost effectiveness of lung cancer screening, and they both come with quite a big but. So the first is all of the models that we've talked about are generally based on major randomized trials or large prospective studies in the first year or two of implementing a screening program. And the second one, the point that I'm going to make, is about the management of advanced disease. So this is quite a revealing slide, I think. This was a paper, or a letter actually, I think, published in JAMA Oncology last year that I found really startling. So they compared screening uptake in the US between 2010 and 2015. And they showed that actually uptake in that period hadn't really changed, despite the recommendation, a national recommendation for lung cancer screening being introduced in between those two dates. And this study showed that of the almost 7 million eligible patients, participants, only 262,700 received it. So we can talk all we want about cost effectiveness of a screening program, but if people are not being recruited into that program, we've got a problem about delivering it in our healthcare systems. And then one of the other things that struck home about this was that over 50% of the smokers that were surveyed in this study meeting the recommendations for screening were uninsured as well. And then just a couple more slides. So I mentioned advanced disease earlier. So clearly if we're screening, we cause a stage shift where we almost switch the proportion of patients with early stage disease with those with advanced disease. And if we can do that in a screening program, that means more are going to get surgery and fewer are going to get systemic treatment. And the way systemic treatment is currently going, I think even if we were to not be able to cure patients with lung cancer surgery, it's going to be cost effective. This is the cost of pembrolizumab, which is approved now for use in the UK at £5,000 per dose every 3 weeks. Next week at ASCO, the American Society of Clinical Oncology, there will be a paper presented that suggests that pembrolizumab is superior to chemotherapy for virtually all patients with advanced non-small cell lung cancer, so those that are expressing any degree of PD-L1 expression. So clearly, as advanced disease management changes and becomes more effective, this is just to our advantage. So some take-home messages. Cost effectiveness varies enormously, and we can affect that in our services in our populations by uptake of screening, nodule management, and I haven't really mentioned smoking cessation, but it is an integral part of making a lung cancer screening program to be cost effective. And just to finish, that cost effectiveness is really important, but it's worth bearing in mind that it's take it with a piece of salt as well, because they're all based on models, and all models are wrong, although we can make use of some of them. Thank you for your attention.
Thank you. We now are happy to present Douglas Wood for a presentation, Lung Cancer Screening Implementation, what we can learn from the US experience. Thank you, Doug.
Okay, thank you. This is a great session. I've learned a lot from it already. And I'll give a little bit of the U.S. perspective of how lung cancer screening has evolved and been implemented in the United States. I do not have any financial disclosures. And of course, the foundation of what we're talking about relates to the National Lung Screening Trial. So I just put the reminder of the 20% mortality benefit. Remember, that's only for 3 screening intervals and does not, that probably, if anything, underestimates the true benefit of patients that were screened for longer. And this being the conclusion of the article about the NLST published in the New England Journal of Medicine, that screening conclusively reduces mortality from lung cancer in high-risk patients. So what are the challenges for lung cancer screening? We've talked about some of them. One aspect is establishing guidelines. I'm going to talk about that briefly. And then how we leverage those guidelines to implement policy, because ultimately this all depends on our various public policies. And then ultimately for patients and providers, primary care doctors to know and accept the data, and then thinking about groups that are actually not studied in the NLST and requires a consensus of medical experts. Ultimately, one needs access and referral to a screening program, and of course, at the end of the day, the people in this room are responsible for quality lung cancer care. So, the National Comprehensive Cancer Network, or NCCN, most of you are familiar with the guidelines, and we created a new guideline panel on lung cancer screening in 2009. I was asked to chair that, and put together multiple working groups, and actually we came very close to publishing guidelines, and then our plan was disrupted by the publication of the NLST. So we went back to the drawing board and had to start over on our guidelines. These are published online. You can readily reference them on the NCCN website. And this is the multidisciplinary panel of experts. And just to point out, the individuals involved include pulmonary medicine, thoracic radiology, surgeons, internal medicine, family practice, epidemiology, and even patient advocacy. So a really wide representation involved in developing these guidelines. And many of you have seen these, but represent which patients are recommended to undergo shared decision-making for screening and which patients are not recommended for screening. So I thought once we published our guidelines and we had a large randomized trial that our work was done. It turns out in the United States that was far from true, because guidelines made by us at the medical level had nothing to do with public policy. And in fact, the United States Preventive Services Task Force is the organization in the United States that sets public policy and therefore coverage decision for preventive services like lung cancer or breast cancer screening. This required a period of changing what I was doing from being a surgeon and a doctor to being an advocate, and going to Washington, D.C., going on to Capitol Hill, working with senators and congressmen, ultimately testifying at a Senate briefing. And this was an effort to bring some public pressure to bear on the United States Preventive Services Task Force to reevaluate their recommendations for lung cancer screening. That ultimately was successful. Hopefully some of you are familiar with this, but the USPSTF did recommend lung cancer screening, and this became effective in the United States on January 1st, 2015. So uptake of 2010 to 2015, for example, has to consider there was no coverage for lung cancer screening until January 1st of 2015 in the United States. This finding by the USPSTF carried the weight of law in the Affordable Care Act in the United States, requiring all private insurers to provide coverage for patients who are eligible for lung cancer screening. So a really major step in public policy implementation in the United States. Then I had my second realization that Medicare, which is our largest insurer in the United States, does not follow the USPSTF. And so we had to go back to work in convincing Medicare administrators, who are the largest insurer in the United States, about coverage for the elderly population, the most important population for coverage, since in the United States, 70% of lung cancer patients are covered by Medicare. So this involved a multi-faceted approach. This was the public approach with an editorial in the Wall Street Journal. This was, again, the effort in public policy implementation with Congress, with the Senate and Congress in the United States. And ultimately, what was most effective is we worked directly with the Medicare administrators, those that determine Medicare implementation policy, with a consortium led by three individuals, myself, someone from the American College of Radiology, and someone from the Lung Cancer Alliance, which is a patient advocacy group in the United States. And this ultimately included the American College of Chest Physicians and the American Thoracic Society, and 50 other cancer centers, university, and specialty societies in the United States. And at the end of the day, this also was effective in allowing Medicare to change their policy and provide coverage for lung cancer screening. That became effective on February 5th of 2015, so 1 month after privately insured patients were insured. So lung cancer screening has only been available, at least covered in the United States, for 3 years. So most of us are familiar with the various guideline groups, and I've not put all of them here, but I've put the European groups, the Canadian groups, American groups. All have recommended lung cancer screening now for patients at high risk, with one exception, which is the American Academy of Family Practice. So the Family Practice Specialty Society in the United States, probably the most important group to advocate for lung cancer screening. So lung cancer screening is now a healthcare benefit in the United States for both privately and publicly insured patients in the United States. So I would argue that this is probably the biggest impact on lung cancer management in a generation, in spite of the huge advances in systemic therapy that we have that treat subsets of patients. We have our biggest impact in decreasing lung cancer mortality from implementation of lung cancer screening. But it's not that simple. There are concerns about lung cancer screening. One is that the benefits in the NLST were overestimated and the harms underestimated. And in fact, when we are talking about preventive services, so an area that most of us are not as involved in, there are close balances between benefits and harms, and minor perturbations of inclusion criteria can not only affect cost effectiveness, but can also affect whether the benefits outweigh the harms. But when we're talking about preventive services, one of the things I try to emphasize is that harm does present in two forms. One of the forms is the one that's most talked about, which is the unintended consequences of evaluation and treatment of healthy patients. But another harm is denying preventive services from those who would have benefited if they had them. So this gets back to which patients should be treated. And what has become a major debate in the United States anyway, that has often been targeted at me because of the NCCN guidelines, because we have recommended a group beyond that studied in NLST that have a lower age and lower smoking threshold, but have the additional risk factor for lung cancer. And in fact, these have now been nicknamed NCCN Group 1 and NCCN Group 2, based upon whether it's the same group that was studied in the NLST or not. And the reasons for this are to understand what the NLST did do and what it did not do. The NLST did demonstrate a mortality reduction in patients that have a substantial risk for lung cancer. The NLST did not define risk factors for lung cancer. In fact, NLST was only a clinical trial, which only used two variables, age and smoking history, for inclusion criteria, for simplicity of a trial that's going to enroll 53,000 patients. So the question is, and the rationale for the NCCN Group 2 patients is the consideration of additional risk factors, because we all have other data about additional risk factors. And if we have the mortality benefit of patients with a certain level of lung cancer risk, what if we identified patients that had a similar level of lung cancer risk? Could we extrapolate that they would also be expected to have a similar level of benefit of screening? So the NCCN Group 2, beyond age and smoking history, includes occupational history, cancer history, family history, and disease history, especially COPD and pulmonary fibrosis. And if I pick just one of them, emphysema, we don't have time to go through all of them. If one looks at the odds ratio of patients with emphysema and the risk for getting lung cancer, it's a 2.3 odds ratio. So patients with emphysema, independently of their smoking history, have over twofold increased risk of lung cancer. And in fact, we've been talking a little bit about risk calculators. We all have seen them online. Every single lung cancer risk calculator uses additional factors other than age and smoking history. And one can even plug sham patients into the Tamamagi model that are qualified by NCCN Group 1 or NCCN Group 2, and so see low, medium, and high-risk patients that are similar in the two groups. And then I think this is especially validated from the Leahy Clinic group, who have a very well-established lung cancer screening program. And they've actually looked at patients that were eligible in their screening program by NCCN Group 1 criteria, which are the NLST criteria, or NCCN Group 2 criteria. And what they found was an identical rate of nodule detection, which was similar to the nodule detection in the NLST, and most importantly, an identical rate of lung cancer detection. So this would seem to retrospectively validate the hypothesis of the NCCN panel, who felt that this group 2 had a similar risk of lung cancer of those studied in the NLST. And finally, we need to minimize the harms, and Dr. Peterson talked some about this and the responsibility of surgeons. And one aspect of limiting harms is minimizing access to lung cancer screening. The problem of that is that although it exposes fewer people to risk, it also uses policy to override shared decision-making and potentially disenfranchises patients that would have benefited from being screened. Another way to decrease harm is to improve how we manage these patients, and this is where it's especially important for the people in this room. Refining the management algorithm so that we don't operate on patients with benign disease, requiring expertise of the surgeons and groups evaluating patients that are screened, empowering rather than undermining shared decision-making, and this provides access to patients and minimizes the harms of downstream testing. And in fact, when you take lung RADs developed by the American College of Radiology and retrospectively apply that to the to the NLST, you decrease false positives by 50 to 75%. So already in the decade beyond where we learned from the NLST, we're able to decrease the false positives. And ultimately, we have to balance the unintended harms with the benefits. And this was shown earlier that the number needed to screen in lung cancer is 3 to 5-fold more effective in terms of the number needed to screen to save a life than breast or colon cancer screening. We need to lower barriers to access. 9 million Americans are eligible for screening, and if screened, that would save about 12,000 lives per year. If we add the 2 million patients that would be added by the NCCN Group 2 criteria, that gives approximately another 3,000 patients, so up to 15,000 lives per year could be saved in the United States. And in fact, the American Cancer Society identified that decreasing disparities in the cancer burden is a primary goal for the American Cancer Society. And as we recognize, our lung cancer patients are a group of patients that suffer from disparities due to being older patients, having higher mortality amongst minorities and lower socioeconomic groups, and less access to screening of rural populations. Ultimately, this is what we're going for. The graph on your left is the current lung cancer current lung cancer survival rate of 18%. The graph on the right is the lung cancer survival rate of all patients screened in the ILCAP group, 84% 5-year survival, an essential inversion of the survival curve as evidenced from the ILCAP experience. So hopefully this can give you a little measure of what has evolved in the United States, which is still evolving in terms of our inclusion criteria, debates that can continue to go on with policymakers. But these are arguments that we have to take beyond the scientific level and take to the public policy level in terms of implementing care for our patients. Thank you very much.
Thank you very much. Unluckily, the time is a little bit late, and one question? Okay, we have time for one question from the floor. I have one quick question for Doug. Which do you think are the reasons why the general practitioners do not like or embrace lung cancer screening?
So the American Academy of Family Practice, I think they made some incorrect assumptions when they did their review. We are actually meeting with them this summer to review that. They made assumptions that essentially the results of the NLST were not generalizable to the population. They felt that there would be a increasing growth of false positives. So I tried to explain to them that actually over time the false positives decrease rather than increase, which from a primary care perspective they don't understand.
Thank you very much, and thank you to all to participate to this session. And we promise next time we will dedicate more time to screening.
Yes. Thank you very much.